These are pictures of dermolipoma, as you can see here on top, as well as with the skin and involvement of the lid itself, as well as solitary ectopic lacrimal gland. And the ectopic lacrimal gland is a simple or complex. It's also associated with ectopia palpebral lobe, and it is highly vascularized, and it may extend to the cornea itself. The vascular tumors is the other category, which is abnormal dilatation of blood vessels that can be even associated with inflammatory conditions or thyroid ophthalmopathy. And it can also be associated with some hereditary syndromes with tendency of hemorrhages. This is an example of telangiectasia present in the conjunctiva. Pyogenic granuloma is another vascular, classified as vascular tumor, that is usually following surgery or a trauma, and can be anywhere from the cornea or the conjunctiva and so on. And also, this is usually easily bleeds, and its removal usually is curable. Another vascular tumor is capillary hemangioma, and this can be either alone or associated with orbital hemangioma and present early in life, and may grow rapidly and then regress in a few years. And their treatment, as you leave them, excise them, or inject them with steroids. And this is another example of capillary hemangioma that has been managed by Huda Al-Ghadir and myself without any recurrences. Cavernous is similar, but it is deeper in location, and it regresses less frequently and also requires conservative treatment. Lymphangioma is another vascular tumor that is slowly progressive, usually involve the orbit as well as the conjunctiva, and usually give the pictures of the conjunctiva as if it is full and chemotic. And if it happens that there is hemorrhage, then it will present differently as like a chocolate cyst. Another form of lymphatic problems is lymphangiectasis, which is acquired dilatation of the normally existing lymphatic vessels present in the conjunctiva. These usually wax and wane, so they might disappear anytime and appear anytime. And usually patients don't have any complaint except of their look. And they look like cystic. So this is a lymphoma. And as you can see, the conjunctiva in lymphomas is present as fullness here. And this is lymphangiectasis. You can see like vessels, but they are having a clear fluid, which is lymphatics. And it may recur and change their locations from the pulpar conjunctiva usually. And they don't require any treatment, just reassurance, because even if you remove them, they might recur in another place. This is also another case. You can see that even with pressing the lids, it moves and look like cystic and dilated. We move now to epithelial inclusion cyst, and this comes as important. It is not common, but it usually follows a trauma or surgery, especially strabismus and the conjunctiva, and usually composed of nests of epithelial cells that proliferate and inside the conjunctiva and substantia propria. And when the central cavity forms, they form cysts, and they are lined by epithelial cells. The content of the cyst is different depending on the origin of the cells. If it is just epithelial cells, usually clear fluid with transudate. If it is mucin secreting cells, they will appear like milky or turbid. Most commonly is after a trauma, as you can see. This is a huge cyst after a trauma, and this is also after another trauma. And this is very interesting that we have reported before. This patient is Ehlers-Danlos syndrome or cornea brittle syndrome, that they have very thin cornea. And because of thin cornea, we usually strengthen the cornea by having a keratosis patch that extends from limbus to limbus. And when we do this, the children usually have a very active epithelium. So they have some epithelial cells between the two layers, the cornea and a grafted corneal tissue. And then they developed this is just the end pictures, but we have other pictures. They form cyst after this, and you can see this is a turbid fluid because of mucin secreting cells present in that cyst and with a level. So this was managed by removing the keratosis patch, applying alcohol to kill the epithelial cells, and putting another keratosis patch. This is rarely happens, but it can happen, especially in children. It can appear as congenital, as in this case that has been reported by Arif Khan and co-authors in the cornea itself. Another form of a tumor, which is hyperplasia rather than tumor, it's called sepipitheliomatous hyperplasia, and it is a benign hyperplasia of conjunctiva cornea, and usually develops in weeks, and it is hyperkeratotic, raised surface with central implications, and it might be confused with the OSSN. The only differentiation between the two that it lacks the transition zone is different than the OSSN. These are the pictures. It looks like a leukoplakia, but it is pseudoepitheliomatous hyperplasia. So with histopathology, the transition zone into normal epithelial, in contrast to squamous cell carcinoma, it has very abrupt demarcation. And this is the pathology for this case. Squamous papilloma is another form of conjunctival tumor, usually benign, and it has some connective tissue fronds, so it has fibrovascular cores covered with the epithelium, and this is why they appear as like dots on the surface, and they are very glistening and transparent. And also it can be pigmented, especially in plaques, and affects children more than adults, and can be unilateral as well as bilateral, and has been claimed that it is associated with the papilloma virus. You can excise it, you can cryotherapy, but recurrence is also common. You can see the pathology, you can see the fibrovascular in the center, and then covered with the epithelium, and this appears as dots when you see it clinically. Location is anywhere. It can be also sessile or diffuse, and there isn't any potential for carcinoma. Pyogenic granuloma may mimic papilloma, as in this case, but it is more or less softer and usually have history of surgery or trauma. As I mentioned, the treatment is just by excision or a cryotherapy, and the recurrence is frequent. And this is another keratocondylarthoma, the same as pseudoepitheliomatous hyperplasia, but it is present in the lid itself. There are other forms of precancerous conditions that, or a stage of the tumor itself, Xeroderma pigmentosa is not uncommon, so we see it frequently here, and they usually present with various tumors, corneal opacifications, pterygium, and so on, and especially for those who are exposed to the sun. Leukoplakia is whitening of the cornea and actinic keratosis as well as dysplasia. The xeroderma pigmentosa, it has some clinical manifestations. Mainly, it has a tendency to develop tumors in the skin and the lids in the exposed area, as well as in the tongue, as well as corneal opacifications, scarring, pterygium, and so on. And these are the clinical pictures. You can see freckles in the skin itself. Patients like this patient who have also bilateral corneal opacification. And their tumor usually behaves very aggressively, and recurrence is common and can also involve bilateral eyes. The survival rate for these patients usually less than 40 compared with the normal individuals. And the ocular abnormality is 40%, as well as some neurological associations. Squamous cell carcinoma of the conjunctiva is a term that has been used in the past. The new term is OSSN, or ocular surface squamous neoplasia. It has also other names such as CIN, which is conjunctival intraepithelial neoplasia. All of these terms have been misused, used in the literature in the past, which means almost the same thing with different degrees of severity. And this was first proposed in 1995. It is more common in certain areas than others, as well as behavior is different from certain, like OSSN in Saudis, they behave more aggressive, they have more recurrence, and they present more invasive, and they might have even regional metastasis. As well as it is also common in Australia, you can see 19 per million compared with other Western countries. In a review of 126 tumors, CIN or OSSN is the most common one of the malignant conjunctival tumors. This is excluding the pigmented tumors, because in previous studies that we did on OSSN, or squamous cell carcinoma of the conjunctiva, I'll just have a summary of these cases. A total of 100 eyes, and we have minimum follow-up of 6 months with 5 patient involvement with bilateral involvement. And the most common presenting sign or symptoms is mass. You can see 71%, then followed by redness or disturbance of vision, pain or etching. Regarding size versus location, if you have larger size, they have a tendency to have some invasion in the subepithelial areas. Also, the involvement of ocular tissues, mainly in the sclera as well as the cornea. And most of the treatment has been received here is excision or excision with cryotherapy. Some of the patients who have late presentation, delayed presentation, they might also have enucleation because of intraocular invasion. And if it is very late, they might also, some of them, they ended by exenteration. I don't think this occurs anymore now, but in the past, it has happened. The recurrence rate, it depends on the study itself, it depends on the region, but in overall, 25 cases recurred in our series. This is an important slide. The most important factor that determines recurrence is margins involved when you excise the lesion. This is why it is very important to make sure that when you excise it, you have a free margin a normal conjunctiva. And the recurrence, it can recur even if the margins are free, but the frequency is much less, 20 versus 50%. Does it occur under age of 30 years? It does. The youngest in our group was 5 years. So this has been reported here as well as elsewhere. So OSSN can happen in younger age group. Many of them, they have also associated with xeroderma pigmentosa. So we have a total of 14 eyes, and all of them, they have under 30 years. So OSSN is an aggressive disease in Saudis, and 10% they have less than 30 years, and they have positive correlations between walled margins and recurrences. And 55% of them are invasive. As I mentioned, recurrence is about 25% in our series. And most of the recurrence happens in the first 24 months. So it is extremely important to have the follow-up in the first year especially, and the peak for recurrences in the first year. In general, conjunctival neoplasia, the incidence is over 100,000, and it affects middle age rather than old age or younger age. And the appearance is very different. They come as in translucent, gelatinous, leukoplakic, which is white, as we saw some of the pictures, and it can be palamatous, it can be fungating, and also it has other rare representation that come with, and we'll see some of the examples. So OSSN is not always present as a mass lesion. It is the most common that they present as a mass, but it can present with others. One of the rare things that can easily overlooked is presentations of finger-like or grayish opacification of the corneal epithelium. And this has been reported before and can even wax and wane on the cornea. Mass lesion or pigmented mass lesion and unilateral keratoconjunctivitis, as well as blepharospasm. This picture was taken from the literature. You can see finger-like grayish opacification of the cornea. Affects only the cornea, not even the limbus. Some of them, they have an extension from the limbus. And these are easily scraped and removed, and this can be the only treatment that is needed. This patient presented to me a couple of years ago with 75, who was 75, and they presented with a little lesion. But when we saw her cornea, it presented some very superficial, irregular surface and opacification. And you can see that with these changes, it gives you a clue that it is abnormal and it is unilateral, and the age is different, and there isn't any other reason. You can see this opacification. And this has been proved to be these are and we just scraped the cornea only, and this was adequate without any recurrence. And the pathology also appears to confirm that she has dysplasia. And it's very difficult to see if the underlying corneal tissue is involved or not. But you can see it is very clear here. But from pathology, because there isn't any tissue that has been submitted. This is another patient who presented to me also before with a blepharospasm in one eye, his left side. And he presented with what looked like pterygium-like lesion with thinning. So it can appear as thinning. These are other examples you can see, like chronic conjunctivitis pictures. This is typical of papillomatous tumor-like mass lesion that is easily diagnosed as OSSN. Or it can be like this one as finger. The location, the most common one is the limbus. And because of various reasons, mitotic activity, exposure to sunlight, UV light, and so on. But it can also involve other lesions such as bulbar, palpebral, fornices. It can be diffuse and can be isolated in the cornea itself without any limbal involvement. And this has been debatable before, but I'll show you one case that has been managed here with only penetrating keratoplasty and no limbal involvement. In the past, we didn't use a lot of medications for treatment. We use excision or kinesin with cryotherapy. And this is one of the examples that has diffuse conjunctival tumor, OSSN, that has been treated with excision and cryotherapy. You can see with the cornea without any recurrence. This is another interesting patient who, one of our colleagues who had pterygium that was removed. That pterygium appeared to be a tumor. Because of thinning, the surgeon elected to put him on a half donut-shaped graft. He presented late with corneal opacification. When we did penetrating keratoplasty, appeared to have some tumor cells present in the interface, as well as invading the cornea to the iris. So we ended with iridectomy and removal of the tumor with a frozen section that was completely excised. So as an advice, if you have any service, don't cover it with something that might hide tumor cells if it recurs. This is the example that I was telling you about, that you can have an isolated cornea only. And this was treated with, the surgeon elected to treat him with just penetrating keratoplasty and approved also to have a tumor cells with epithelial time. But usually the tumors they have, even if they are in the cornea, they have an extension from the limbal area, most of the cases. Does it occur in the literature as an isolated corneal lesion? It does, and it has been also reported, but it is extremely rare to have just the tumor present in the cornea itself. Unusual presentation, as we mentioned, precorneal extension, usually massive precorneal extension without Bowman's involvement. Diffuse papillomatosis, pigmented tumor, cicatricial ocular pemphigoid, endophytic. So instead of growing outside, it might grow inside and cause invasion. Necrotizing scleritis. Ocular perforation has been presented as a primary presentation. It has also it has happened that it is as a recurrence, as well as orbical psoriasis. These are tumors, aggressive tumors. You can see in this picture, fungating exophotic a tumor-like that has been neglected with delayed presentation. This is the same patient. He presented with blepharospasm. You can see he has blepharospasm. His tumor here is not a real mass, but he has like pterygium, as well as thinning above and below of the pterygium. And this patient was excised with a frozen section. It has some scleral involvement. And then he lost follow-up. And 11 months later, he presented with perforation, with intraocular involvement. So perforation can present in these tumors, especially in aggressive lesions, as a primary tumor or as a recurrence, as in this case. These are the extreme of the tumor itself. As I mentioned, does it occur in younger age group? It does, and this has been reported before, as well as we have seen in our series here. Diagnosis is mainly clinical, but you can get help from Ross-Bingal staining, and this is usually aiding in determining the extent of the tumor itself. OCT is another tool, a pap smear or a cellulose paper to get the tumor cells. ACTAP, if you are questioning, there is an extension and biopsy. The treatment, surgical treatment, is mainly, which is widely used, is excision, sometimes combined with the cryotherapy. And the cryotherapy is usually nitrous oxide. Liquid nitrogen is rarely used because it is very difficult to control the spray of the liquid nitrogen. So combined excision with cryotherapy of the margin is used to be a very common practice. It has become less now because of the medical therapy. The medical therapy, the main three drugs used is mitomycin C, 5-fluorouracil, as well as interferon alpha 2 beta eye drops. Both have similar effects according to literature. Interferon probably has less complications, but it is more expensive and can also be injected into the lesion itself. The course is very variable from one paper to another. Some people use it for 4 days every week for 4 to 6 weeks. Some people use it for 2-week cycles and then stop for 2 weeks. And some people use it for 4 weeks continuation. You can see from this slide that the recurrence rate is very wide, from 15 to 55, depending on the series that you are looking at, as well as how you manage the case. With excision only versus excision with cryotherapy, you have more recurrence rate. If you have margins involved, also the recurrence is much more. And also, you can see the presentation in this paper, the nodular is the most common, and you can see the age group is in the middle age. These are some of the side effects of these three main medications that can be used. They have very similar effect with almost similar side effects that include corneal conjunctival hyperemia and punctate erosions in the cornea, sometimes to the extent of limbal stem cell deficiency that with a prolonged use and irritation of the conjunctiva. In 2003 versus 2012, the shift has been more towards medical, so 50% of the cases usually managed by medical versus excision. If they have very the extensive surgical excision complications, mainly is limbal stem cell deficiency, symplepharon, scarring, and so on. There is a new drug, it's called topical Cidofovir. This has been reported in 6 patients as a drug after the previous treatment of these cases, either by excision or by other medical treatment. It is important to have wide excision and to be delineated by Ross-Bingal. And if you have any invasion or doubt of the invasion, you can do keratectomy or sclerectomy with lamellar dissection and cryotherapy. And it is important when you apply cryotherapy, do it as double freeze, freeze-thaw cycles with slow freezing and rapid freezing and slow thawing. We come to another classification of tumors which are pigmented. Nevi. Nevi is the most common conjunctival tumor. And many of these patients, they don't usually present. Many of them, they don't know that they have nevi because many of them, they have nevi, but it is very flat and less pigmented. And they might present sometimes with inflammation associated with this. And they come at puberty, become more prominent. And can also be elevated, not only flat. And 20% of the malignant melanoma arise from them. They usually treated just by leaving them or just by excising them for cosmetic reason because they are so common. Melanocytic proliferation, it's just presence of melanocytes present in conjunctiva, and it is more abundant in blacks. The nevi, they have different types, junctional, subepithelial, compound, blue, and associated with congenital melanocytosis. And these are the pathology of these four types. Junctional, which is between the epithelium and subepithelium. Subepithelium is more or less deeper in layers, and the compound that might reach also superior, surface. And they usually move with the conjunctiva, say they are mobile, all of the three types. These are examples of them, and they can also be cystic if you excise them. The blue nevi, the difference, they don't move the conjunctiva. You can see them as blue nevi. And congenital melanosis, it's a diffuse blue nevi and usually unilateral, sometimes associated with also lid pigmentation. And the iris can be also a cause of heterochromia, so they appear darker. These are examples. You can see the skin and the conjunctiva as well as iris is involved. And this is another patient. You can appreciate the heterochromia where the affected iris is darker. Primary acquired melanosis, this is very important and it is precancerous. Most of the tumors of melanoma conjunctiva comes from this. These are, so if you see some patients like this pigmentation of primary acquired melanosis, you have to observe the patient very closely. Racial is similar to melanosis, and as we mentioned, more on blacks and perilumbal, as well as the corneal involvement. You can see holes of these pigmentation present in the cornea, especially when they present with allergic or vernal. You can see some of these epithelial cells grow over the cornea as black streaks. Malignant melanoma, as we mentioned, acquired melanosis in 60–70%. It comes from there. And extremely rarely that involves the central cornea. This is pictures of melanoma of the conjunctiva. There are other forms of rare conjunctival tumors that you might see in your career or you might not see. But just in case if they present, remember that there are rare conjunctival tumors that can be seen, but should be differentiated. And these are such as mucoepidermoid carcinoma, which originates from the mucin secreting cell of the conjunctiva, and they behave more aggressive. Also nodular melanoma, pleomorphic blastocytoma, and xanthogranuloma. And these are examples of spindle cell carcinoma, cystadenoma, nodular melanoma, melanoma in situ, and plasmacytoma. They appear a little bit different than OSSN. And myxomas, as well as pleomorphic in the caruncle, and histocytoma. And this patient presented to me also, which is It was a puzzle to everybody because one eye had PKP somewhere else, so we don't know any pathology, what has been going on. It was bilateral with a relatively clear cornea, graft, I mean, in his left eye. But it was a tumor that covering the right cornea itself. And it appears like keloid. So the primary diagnosis is probably keloid. And he was young, I mean, in his 30s. And of course, he has only light perception. We did excise it, and I don't know if it will work or not. And it appears that it is a tumor covering all the cornea and causing melting of the cornea itself. So we have to do a big corneal sclerotic graft, as you can see here. And then later we did a cataract extraction for him. It contains histiocytes as well as giant cells. And the diagnosis was xanthogranuloma, and this was reported. It is extremely rare to see these tumors, but it can happen. We move to iris tumors, mostly nevi, which is usually flat and present darker than the iris itself, or malignant melanoma. In our region, it is extremely rare to see iris melanoma, but it can happen. And this is a patient, a Lebanese patient, who presented to me. You can see he is very suspicious of the melanoma because of ectropion, because of the pupil margin, because of even architecture of the iris itself is different. So this was managed by iridectomy. And then we suture to this, and as expected, this suture broken down. So we have to use artificial iris, mimicking his color of the iris that was ordered. And this was followed for years without any recurrence of the tumor. And these are the clinical pictures: ectropion, iridis, vascularization, cataract, sometimes even synechiae, as you can see in here with another malignant melanoma. You can see peripheral anterior synechiae there, and sometimes extending of the ciliary body or iris through the sclera itself. This is another tumor that presented with very dark pigmented iris, and the tumor, we have an OCT here, but it's not in the picture, that it is adherent to the cornea as well as in the iris itself, and it has a lot of pigments on the surface of the iris. We elected to do biopsy, aspiration needle, and it tends to be non-melanoma. So we excise this with sector iridectomy, and during the procedure, when we enter the anterior chamber, the pigments were diffusely present in the anterior chamber. So the diagnosis was melanocytoma. And the prognosis for these tumors is very good. We come to an iris cyst with the congenital one, which is more or less very benign, rarely treated, rarely needs to be treated. Iris pigment epithelial cyst. And these have been classified into different categories based on the location, and they are congenital, and they consist of the two layers of neuroectoderm. Sometimes if they mid-zonal or peripheral, they are better seen after you dilate the pupil. But it can be at the pupil, it can be mid-zonal, it can be peripheral, it can be also detached in the anterior chamber or in the vitreous cavity. It requires no treatment unless they cause any pressure problems or visual symptoms. These are examples. You can see one in the anterior chamber here and the other one in the vitreous cavity. These are taken from literature with a pupillary, and they are multiple. And can also, this patient has also very peripheral. You can only appreciate the gonioscopy or with dilation and maybe associated with the lens coloboma. We move to another aggressive tumor or cyst, which is iris epithelial inclusion cyst. Fortunately, this is a rare condition, especially now with the new surgical procedures, but it can follow trauma itself, especially if you have some conjunctival epithelial cells taken into the anterior chamber, and then over the iris, they form these epithelial cells and form the cysts. They behave aggressively, and they usually grow very fast, and they need to be treated like any tumor. This is the same pictures that we saw before between two layers of the cornea, the grafted keratopatch for Ehlers-Danlos syndrome, and you can see the posterior part of the cornea is pushed to the anterior chamber because of the cyst and cyst fluid that I mentioned, that it is from mucin secreting cells. This is why it has turbid with the level. For this patient has multiple graft surgeries, but he developed cysts. And this also has another trauma. You can see a scar here that have been managed. I have managed the 22 cases of iris inclusion cysts by dissecting them with viscoelastic without any recurrence. It has been reported in the literature. You can remove as a block, remove the cornea, the iris, sometimes even the ciliary body, which is very aggressive treatment. And many of these patients had ended with loss of either loss of vision or loss of the eye itself. With less aggressive, by dissecting these and aspirating these is probably more adequate. This slide is important just to indicate to you this patient has been seen here, but the surgeon elected to observe him, and with time, you can see the dates with increase in size after time. So if you see any patient with iris inclusion cysts, it should be treated immediately rather than wait until it grows up. This is another patient who has been seen in the last few weeks. This is different with no history of trauma, no history of surgery, and it was for us very difficult to believe. This patient has excellent vision and no problems, so we elected to just observe him. This is his cyst. You can see present at the angle, and with time, this is his OCT, and with time shrank. And this is very rare that happens, but if you have a patient who doesn't want surgery and you have to follow him closely, and still we are following him up, but he didn't have denied any history of trauma or surgery. Another tumor, which is juvenile xanthine granuloma, it usually affects children, especially less than 1 year, and usually present with unilateral yellow prominent blood vessels that easily bleeds. So many of these patients present sometimes. It can, as I mentioned, present as spontaneous hyphema. It's also associated with skin lesions, single or multiple elevated and pink. They have a granulomatous infiltrate with a lipid-containing histocyte, similar to the one we have seen in the cornea itself. So, but it is the locations in the iris. And has also other locations in the iris, ciliary body, anterior choroid, and so on. And this is the histopathology as well as skin lesion of this patient. Thank you. Any questions? Yes. ما اسمعك.
Did you use any drugs during the follow-up or steroids?
Yeah, like any surgical procedure.
No, I mean the last case where you selected just to observe the iris cyst where it's shrunk by itself.
Nothing.
Nothing, no drops.
The treatment for iris pigment epithelial cysts like this one There are people who I mentioned very aggressive and go with the en-bloc dissection, removing the cornea, iris, as well as ciliary body if it is involved. There are patients who just inject sclerosing agents like alcohol to shrink it, and this is risky if it escapes to the anterior chamber. We always elect to dissect and aspirate and then do iridectomy. But to answer your question, that patient didn't receive any medication. Yes?
With viscoelastic,
Uh,
the inclusion cyst. How only using the viscoelastic to
I
dissect?
have a video that I prepared to the American Academy with various iris cysts that we usually we create positive pressure first of all, dissect the cornea with the viscoelastic, separating the iris cyst from the cornea itself, and sometimes even vacuuming the corneal endothelium just to remove any remaining cysts, and then aspirating with the partial depth limbal wound, and then after creating positive pressure in the anterior chamber, filling the iris cyst with viscoelastic, and then prolapsing it and do iridectomy around the cyst itself.
Thank you, Dr. Ali. I have a question regarding the corneal squamous cell neoplasia. You mentioned that you prefer scraping, but is there any role for topical chemotherapy in such cases?
For
A corneal, isolated corneal squamous neoplasia.
it can happen. It can be used for sure, but the cornea is very easily managed by excising the tumor itself, because Bowman's is usually more or less resistant for invasion. So once you remove it, it's very easy, much easier than exposing the patients to multiple medications. I mean, medications for a long period of time, and the conjunctiva is free.
And in the cases you've got the recurrence rate for those cases without a topical chemotherapy, did you notice any recurrence?
In the
or
cornea,
yes?
we only had one cornea for this case. It's extremely rare to find only isolated corneal tumor, and some of the oncologists don't believe that corneal OSSN exists because it has always involvement of limbal. But it has been reported and we have seen it. Okay, thank you.